So, good morning, friends. So, after two overseas talks, I'll just quickly go through one of the cases representative of what we are discussing over the last 2 days. There was this 69-year-old male from Tanzania who had a large painful wound in the leg for 4 months. He was a hypertensive old CV stroke with a motor of 2/5 in the right leg. He was wheelchair bound most of the time. Poorly controlled diabetes. And the relevant local examination, I'll just tell you just about what is locally found. There's a large 20/10 wound anteromedially and the lateral aspect of the distal leg. There's a lot of slough and tenderness with signs of ischemia. The distal pulses, meaning the dorsalis pedis, ATA, PTA, were not palpable. And this was what the wound looked like. You can see large thing almost surrounding the entire lower part of the leg, the medial lateral aspect as well as the ankle. So because there was a large wound here, we said probably a duplex will be challenging. Most of these cases when we send down for a duplex, they say the patient is in bandages and so technically not possible. So we said probably a CT is a better option, and if you see the CT, you'll realize that probably this is a severe BTK disease in the right leg, the affected leg. We did an angio, and this is what you can see on the angio. Just below the knee joint, there is a high-grade stenosis, and what you can see is a single vessel disease. The peroneal. Yeah, next is not playing. Is the video playing now? Video is not playing. Yeah, does it play?
No, it's not.
It's not playing. Anyway. Right, but let's see if this plays. This doesn't play as well. Huh? Yeah, play it, yeah. Does it play? It's not playing. It's not connected. The player is not here. Anyway, so I'll rather than waste time on this, I'll just quickly go to the slideshow and come to the core thing. So basically what we found in this was that when we did the angio, we found that the AT and PTA were forming just above the ankles as from the branches of the peroneal anterior and posterior branch. So typically as a surgeon we feel that ideally this would be a bypass where we take a piece of vein, reverse it and bypass it to the ATA, PTA. But unfortunately there's a large area of slough and the wound had almost circumscribed, it was circumscribing the ankle. And so there was no area where we could actually plumb the vein into. And moreover, the quality of the GSV was not that great. So, what we did was we said probably we'll do a POBA first. So we did a POBA with a 3.5 millimeter balloon, but it was non-yielding due to circumferential calcium. You can see there's still a residual lesion there. And so what we used was a Stealth 360. Now this probably would be the ideal lesion where you have a single vessel unable to do a bypass in a no stent zone, and so we use this, and let's hope this plays. Does this? Yeah. I think So I think this is playing. So basically, this is just a demo to show you exactly what the Stealth 360 does. You have ideally this is meant for short segment calcified lesions. I find those are the best cases where you can use an atherectomy because the muck that goes down is minimized, and as you can see, this diamond back actually it oscillates 360 degrees and literally like a sandpaper shaves off the whole plaque. So this is a brief video just to show you what actually it does. So what they say is that the particles that come out are very, very small, so you really don't need a filter. I'm not too sure about it, but basically why I prefer it only for the short segment, short segment lesions, so I don't particularly anticipate too much of muck. So that was our, and I don't know, many of you might not have used it, but when you use it, it's actually like it makes the sound of an aircraft actually landing, it's, it's that loud. So you can actually get the feel of something being shaved inside. So that's the video of that. And as I said, the technology is designed to, it's a diamond coated head which basically sandpapers everything off. And following this, we use the Magic Touch Sirolimus coated balloon, and that was what we got. I'll show you in the next picture. If you take a zoom of it, this is what it looked like. If you magnify, say, we got a fairly decent luminal gain with a post-atherectomy and a Sirolimus coated balloon. Thereafter, we took the patient up for a debridement and then initially a dermal substitute, and we had a good wound healing. And end of the story is that basically he had a healed wound. He came back, he went back home, and as we discussed yesterday also, the patency, I'm not really bothered about the patency, whether it is there or not. The fact is that he came with a large wound which has healed, which we have managed to heal, and that's a non-functional leg in the sense he's wheelchair bound. So his main primary issue was that he had a painful large wound, and any which way we've got it to heal. Thank you.